Hi, welcome back to your prescription for medication education. My name is Enmi, and I'm a passionate pharmacist, and I'm here to bring you quality information regarding medications and health-related topics, and in the process, expand my own knowledge. Today, I'll be talking about angiotensin receptor blockers. Just like last time, we'll start off the video with 5 questions, and at the end of the video, I'll go ahead and provide the answers. Question number 1, which of the following best explains why ARBs produce less cough than ACE inhibitors? Which ARB has an FDA-approved indication for cardiovascular risk reduction in patients 55 years of age at high cardiovascular risk who are unable to take an ACE inhibitor? A patient with advanced chronic kidney disease requires an ARB. Which pharmacokinetic property makes telmisartan advantageous in this setting? Question number 4. Which ARB is most strongly associated with sprue-like enteropathy? And the final question, according to observational data, which of the following statements is correct regarding late gestation exposure? Today's video will be shorter because most of the information I went over in my last video on ACE inhibitors applies to ARBs. If you're looking for more detail on adverse effects, contraindications, and drug interactions, I recommend watching that video. In my last video, I reviewed the RAS system, so let's jump right into reviewing how angiotensin receptor blockers work. ARBs selectively block the angiotensin II type 1 receptors. This prevents angiotensin II from binding to the receptor, which blocks vasoconstriction, aldosterone secretion, and sympathetic activation. When we say ARBs selectively block angiotensin type 1 receptor, this simply means that they have a higher affinity for this receptor. ARBs have over 1,000 times greater affinity for this receptor over angiotensin type 2 receptors. With ACE inhibitors, there is a decrease in the level of angiotensin II, but with ARBs, we simply block the effects at the receptor. We end up with elevated levels of angiotensin II. This can potentially have some beneficial effects because angiotensin type 2 receptors activation produces vasodilation and inhibits cell proliferation. ARBs also do not affect bradykinin metabolism, which explains their much lower incidence of cough compared with ACE inhibitors. Examples of ARBs include candesartan, losartan, and valsartan. I'll go over a handful of the ARBs in this video. There are currently 8 approved ARBs available in the US. ARBs reduce blood pressure by about 8 to 9 millimeters for systolic and 5 to 6 millimeters of mercury for diastolic at standard doses in patients with hypertension. ARBs are just as effective as ACE inhibitors in terms of lowering blood pressure. There is some evidence that might suggest ARBs may produce slightly lower blood pressure, but the difference is modest. Some of the adverse effects include acute kidney injury, hyperkalemia, and dizziness. Contraindications include pregnancy and hypersensitivity. Some of the warnings include hypotension, aortic stenosis, renal impairment, and hypertrophic cardiomyopathy with left ventricular outflow obstruction. Some of the FDA-approved or common clinical uses include acute coronary syndrome and chronic hypertension. Losartan was the first ARB approved back in 1995. It is available as the original tablet formulation, which is Cozar, and as a commercially manufactured oral suspension, Arbly, a 10 mg per ml product approved in 2025. Previously, losartan was compounded to accommodate weight-based dosing in children, most commonly at a concentration of 2.5 mg per ml. Because of this new formulation, it's recommended that prescriptions written for losartan suspension now include the concentration and the milligrams desired to reduce the risk for dosing errors. The dose for losartan ranges from 25 milligrams to 100 milligrams per day, given either as one dose or as 2 doses for hypertension. In heart failure with reduced ejection fraction, higher doses up to 150 milligrams per day have been shown to improve outcomes compared with 50 milligrams based on clinical trial data. Irbesartan's brand name is Avapro. It's available in 75, 150, and 300 milligrams. For hypertension in adults, dosing typically ranges from 150 to 300 milligrams once a day, with 300 milligrams as the maximum recommended dose. There is limited data available for the use of irbesartan in children, but for children 6 and up, an additional dose of 75 milligrams is utilized in pediatric dosing. Irbesartan exhibits insurmountable antagonism at the angiotensin I receptor, whereas losartan acts as a surmountable competitive antagonist. This essentially means that irbesartan binds at the angiotensin 1 receptor with high affinity and dissociates slowly, resulting in a blockade that is not easily overcome by increasing angiotensin 2 levels, unlike losartan. Telmisartan's brand name is Mycardis. Telmisartan is unique in which it has an FDA indication for cardiovascular risk reduction with a targeted dose of 80 milligrams per day. For patients unable to take ACE inhibitors, telmisartan can reduce the risk for MI, stroke, or death from cardiovascular causes in patients 55 years of age or older. High cardiovascular risk is defined as having a history of coronary artery disease, peripheral arterial disease, stroke, TIA, or high-risk diabetes with evidence of end organ damage. Telmisartan undergoes predominantly biliary elimination, meaning hepatic impairment or biliary obstruction can significantly increase systemic levels. This makes telmisartan advantageous in patients with severe chronic kidney disease because it does not require dose adjustments, although renal function should still be monitored. Candesartan's brand name is Atacand. Candesartan siloxetil is a prodrug that is completely converted to its active metabolite candesartan during gastrointestinal absorption. It's formulated in 4, 8, 16, and 32 milligram tablets, and its maximum recommended dose is 32 milligrams per day. It requires dose adjustments for patients with a creatinine clearance of 30 or less, with a recommended maximum dose of 16 milligrams per day. Candesartan has the highest affinity for the angiotensin 1 receptor amongst all of the ARBs, with a binding affinity of about 80 times greater than losartan. It has a slow dissociation rate from the receptors, which allows it to have an extended antihypertensive effect that exceeds what would be expected when looking at its plasma half-life that ranges from 5 to 9 hours. For this reason, it can produce antihypertensive effects for up to 48 hours. The brand name for olmesartan is Benicar. It has demonstrated strong antihypertensive efficacy in head-to-head trials. In one comparative study published in Clinical Therapeutics in 2004, olmesartan 20 milligrams daily produced greater blood pressure reductions than losartan 50 milligrams, valsartan 80 milligrams, and irbesartan 150 milligrams. Overall, ARBs are considered therapeutically comparable when titrated accordingly. Earlier I mentioned ARBs have a lower incidence of cough and angioedema compared to ACE inhibitors. ACE inhibitors cause cough in about 5 to 35% of patients, and ACE inhibitors have roughly a 3.2-fold higher cough risk than ARBs. ACE inhibitor-associated angioedema occurs roughly in 0.1 to 0.7% of patients and is about 2.2 times more common with ACE inhibitors than with ARBs. The American Academy of Allergy, Asthma, and Immunology notes that most patients who experience ACE inhibitor-induced angioedema can use ARBs, though with an estimated recurrence rate of somewhere between 2 to 17%. The risk for angioedema is higher in African Americans, older adults, smokers, and women. The risk for angioedema is the highest within the first 30 days after starting an ACE or an ARB, but can still occur years later. The KIDS list stands for Key Potentially Inappropriate Drugs in Pediatrics, which is an evidence-based guide created in 2020 by the Pediatric Pharmacy Association. ARBs are included on the KIDS list as use with caution for neonates younger than 1 month, due to the risk for renal tubular dysgenesis. In my last video, I reviewed RTD, so feel free to watch that video. What's interesting here is the exclusion of ACE inhibitors on the KIDS list for the same reason. In pregnancy, ARBs carry a significantly higher fetopathy risk compared to ACE inhibitors. The fetopathy rate with ARB exposure after 20 weeks gestation is 29.2% compared to only 3.2% for ACE inhibitors, with 87% of ARB-exposed newborns developing complications versus 48% of ACE inhibitor-exposed newborns, based on a prospective observational study from Weber-Schoendorfer published in the Journal of Hypertension in 2020 and a systematic review published in Hypertension in 2012 by Bulow et al. Olmesartan is unique because it is disproportionately associated with a sprue-like enteropathy. This condition is called sprue-like enteropathy because it mimics celiac sprue both clinically and histologically. This condition is characterized by severe diarrhea, which occurs in about 97% of cases, weight loss, and frequent hospitalization. Symptoms are often more severe than typical celiac disease. Olmesartan-associated enteropathy frequently involves the entire gastrointestinal tract. Celiac serologies such as anti-transglutaminase and anti-endometrial antibodies are typically negative, distinguishing this from celiac disease. The most distinctive feature is complete clinical and histological resolution after olmesartan is discontinued. Symptoms typically improve within 2 to 3 weeks, with mucosal healing documented at 3 to 6 months. And the answers for the questions I presented at the beginning of the video is 1 Bravo, 2 Charlie, 3 Charlie, 4 Delta, and 5 Bravo. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Also, feel free to leave me any comments. What can I do better? What do you like? Anyways, thank you and have a great day.